Hello, everyone. Thanks for joining. So we'll be continuing on the investigation series, and I wanted to talk about ocular ultrasound today. It's not a particularly long tutorial, but I wanted to touch on essentially what it is, some brief sort of comments on its indication, how to do it, and then also just kind of going through some common things you might see when doing a B-scan ultrasound in your own clinical practice. So essentially, it gives you a 2D picture. It's a sort of brightness scan. That's where the B scan comes from in terms of the letter B. And then obviously you're going to get different sort of levels of echoic strength. Kind of the brighter the tissue, the sort of higher its echoic strength. Or sometimes it means the denser the tissue is. It's very quick. It's really easy to perform. It's completely non-invasive. You can just sort of put this, bring an ultrasound in and then just perform it while the patient is sat there in front of you in clinic. And there's lots of different reasons to do things. So when do you want to sort of start thinking about doing a B scan? So in cases of trauma, you sometimes want to be a bit careful, especially if you're worried about an open globe. You might want to kind of probably avoid a B scan if you think you're going to exert any pressure onto the globe and cause any further prolapse of any contents. But if, for example, you're not really sure what's going on, if the eye seems formed, but you want to sort of take a better look, then a B scan can help with an assessment of the posterior segment, especially if you're concerned that there may be an intraocular foreign body. An ultrasound, again done gently, can give you an idea as to whether or not there's anything kind of picking up any signal within the eye. The most kind of common situations that you'll find a B scan is being done is usually when there's no fundal view. So either it's in the context of someone, for example, who's had a vitreous hemorrhage, any sort of intense inflammation, where it's difficult to get a view of the retina and you want to know what it sort of looks like, that might be a reason to do it. Or, for example, if you have a very dense cataract and you're wanting to assess a patient, for example, with a white or a brunescent cataract with no fundal view, and you just want to make sure that there's nothing sort of glaring from their retina, a B scan may be helpful there. And sometimes even with a fundal view, sometimes there'll be things that you see in the retina or in the fundus that makes you want to do a B scan. So with optic disc swelling, you may want to consider doing something, especially if you're looking at something atypical, perhaps unilateral. Some choroidal folds, sort of, consider doing a B scan to look for any masses behind the eye. It's much quicker than sending a patient off to a CT scan. You can just do it straight away. And if, for example, you actually see anything within the retina, so if you see a nevus, if you see an actual mass, if you see something that's elevating that retina, then a B scan can also be helpful as well. And there are, kind of formal ocular ultrasounds that you can get, but in order to just sort of, for your own practice and in clinical care, being able to sort of do an ultrasound is a key skill really that helps you sometimes narrow down a diagnosis or at least rule out more serious things in the posterior segment. So how do you do it? You can sort of just start off with a direct view. So with the eye closed, you're applying the probe onto the eye and you're just getting a direct view straight ahead. But it can also be useful to ask the patient to sort of look up, down, left, and right, and then apply the probe as well on the closed eyelid to try and get as much view of everything that's going on in that retina from a 360-degree point of view. And that can be really helpful, especially in VR clinics. And then there's also the dynamic views. So, have this a probe on the eye, ask the patient to move left and right, and actually see if you are having something that's hyperechoic in the posterior segment, how is it moving around the eye? Is it attached at any point to the sclera? Are you looking at retina? Are you looking at vitreous hemorrhage? Are you looking at intraocular foreign body? And a lot of that has to do with how the eye actually moves and what you're looking at is actually moving. So in the normal eye, you'll have a scan that looks similar to this. You've got the lids closed at the top, very top of that image, and then you can go through slowly looking at the cornea, your anterior chamber. You've got a sort of view of the iris, the lens, the ciliary body, and then you're going to be looking within that vitreous cavity, which should be completely nice and clear. The retina, which should be completely flat along that sclera. The globe should have a nice sort of form to it. It should be nice and spherical. And that optic nerve, you can see that there's nothing sort of hyperechoic there at the optic nerve, and you have this shadow as to where that nerve exists. And this is what you're going to see in the normal eye. And sometimes it can be helpful where even when you have no suspicions of anything going on, maybe perform an ultrasound so that sort of what normal is becomes more apparent to you. But also the flip side to that is when you do have a pathology that you don't need a B scan for to diagnose, performing a B scan anyway can again help you pick up your skills on how to find the pathology and what that pathology looks like. So if somebody has a retinal detachment, you know exactly where it is. Go and find it with the B scan so you know how to use the B scan, how to orientate your probe, and also what that retinal detachment would look like. So for the sort of second part of the session, I'm just going to kind of quickly go through some common scenarios that you're going to come across with your B scan, what they look like. So with a PVD, you know, this is someone who's going to have a very faint hyperechoic line in the sort of posterior part of the vitreous cavity. Your retina will be nice and attached. These are obviously clinically, if you look at the patient, it depends on why you've done this. So for example, if you have a fundus obscuring hemorrhage in the context of a hemorrhagic PVD, then potentially an ultrasound can help you. But this PVD there is evident where you can see this posterior hyaloid face at the back of the eye telling you that that vitreous has detached. With a retinal detachment, you'll get this quite bright hyperechoic line. That's your retina. And it's completely detached from the back of the eye. Now, this is a picture of somebody with a completely total retinal detachment. You've got this sort of funnel sign, and you can see it's attached there around the disc, and then it's completely come off elsewhere. And sometimes with localized retinal detachments, obviously these are going to look slightly different. And you know, like I said, either total or subtotal. And importantly, when you're doing these dynamic views, this retina is going to be mobile, flapping around the eye, looking very, very detached. A vitreous hemorrhage, this can vary depending on the age of the vitreous hemorrhage and the extent of it, but it's essentially a sort of high, hazy, hyperechoic sort of signal coming in from the vitreous cavity. There's nothing sort of, especially if it's in the context of a pure vitreous hemorrhage, perhaps in a diabetic patient, you're not going to be concerned of any retinal detachment. That retina should be nice and flat. And again, it can be quite mobile in the eye. With an intraocular foreign body, typically what you're going to see is that there'll be a hyperechoic object, usually somewhere in the eye. It can be in the lens, it can be lodged in the ciliary body, it can be lodged in the sclera, the cornea. Essentially, you get this very discrete hotspot on your ultrasound, and that gives you sort of alarm bells as to what could be going on, especially in the context of a high risk history. And then you also may find things that are associated with intraocular foreign bodies. So they may have a vitreous hemorrhage that you might see on a P scan. They may even have a retinal detachment, for example, potentially a globe rupture with corrugated lines at the sclera. And all of this sort of points you towards wondering what has happened to the patient and whether or not they're having any problems. Moving on, so you may see this less often in practice, but a melanoma is usually a sort of hyperechoic mass at the back of the eye. You get this sort of typical shape of it being quite dome-shaped, potentially mushroom-shaped. Clinically, you may find that the retina is slightly elevated. It may have some overlying exudate, maybe some subretinal fluid, all giving you that sort of red flags as to a melanoma. But B scans can be very helpful to monitor these sort of growths at the back of the eye, even for measuring, deciding on things like plaque brachytherapy, and even when actually applying the plaque brachytherapy, ultrasound can be helpful to actually apply the plaque itself. And then also optic disc drusen. So in a patient with kind of an atypical optic disc swelling, no positive history, potentially a completely clear CT scan. If you performed a B scan, you can see this very, very bright signal at the disc where that calcified optic disc drusen is. And then you'll get the shadow effect behind it where you get a complete loss of signal because that bit of calcified sort of drusen is completely absorbing that ultrasound and nothing is sort of getting through it, which is why you get that sort of shadow effect. So in summary, there's lots of uses to ultrasound. You can either use it clinically where the diagnosis isn't clear. You can use it for monitoring purposes in patients with masses. You can use it for treatment and applying treatment. For example, in plaque radiotherapy, as I said, and really do use it as an adjunct to your clinical exam. So if there's anything that you're uncertain of, a B scan can sometimes be a helpful way of knowing, how is the globe doing overall. So, practice using it in your clinical practice. Consider using it even when you know what the diagnosis is so that you can learn how these things look in real life. So thanks for joining. Please do remember to fill out the feedback. That link is in the description. And thank you for joining again, and we'll see you at the next one.